joint section, the last joint to be covered, the ankle and foot. I will request all of you to go through this YouTube video on the biomechanics of the ankle. So it's very important because if you want to make sense about the ankle and foot, you must have an idea about how all these axes pass through, like the ankle, the subtalar, the metatarsal joints, everything. So ankles, the joint axes are different and the movements are a bit confusing because they occur in different planes. So it's necessary that we have basic idea. It will be good that you go through this video many times so that you will get an idea about the movements of the ankle. Then when you come to the definitions of the movements, what you call the planes and the movements, there are some confusions actually. You know the hallux valgus and varus, then you take the reference as the mid sagittal plane of the body. Okay, but when you call about the metatarsus adductus, then you are taking actually the foot axis as the reference. When you call hallux valgus, that is the midpoint, mid plane of the body, mid sagittal plane. But when it is metatarsus adductus, you are taking the foot axis. So that kind of a bit confusion is there in the definition when you come to the foot. So always expect that some textbooks will use different terminology. So one movement may be having a name in one textbook and the other textbook can give another name. That is very usual. And these are the usual movements that you have. And the supination and pronation. So here some of the textbooks actually interchangeably they use inversion, supination, inversion, pronation, supination and eversion. Okay. So these are the axes. I again request you to go through the video to have a proper idea of all these axes and how the movements occurs. But you know basically the movements, the inversion, eversion, the dorsiflexion, plantar flexion, adduction, abduction and the internal and external rotations, and the combination movements of pronation and supination, where one is the abduction, lateral rotation, and you have the dorsiflexion, and other is the just opposite when you have the inversion, plantar flexion and medial, or the adduction. Okay. Now coming to the proper examination. With that basics in the mind, we are coming to the proper examination. So first is the inspection. In the inspection, one of the most important thing is the posture. So we have almost in many presentation you heard about the importance of the posture. So again you must always remember these pictures in Kendall. See these pictures again and again to have an idea about the normal posture. And you will have different kind of posture. So always when a patient come with a complaint of the ankle or foot, you have to look at the position of the lower limbs, the whole posture, the position of the lower limbs, especially the knees. Okay, so you will see that in the first picture that's almost normal. The second you can see that the patella, you can always look at the patella, how the patella is located. So that is actually there is an internal rotation or the tibial. In the femur there is an internal rotation of the patella, you can see the patella, and that is slight pronation of the foot. That is, there is not too much pronation, there is slight pronation, but the other there is a knee valgus and there is some amount of pronation. And here you can see that the foot is almost okay, but the first picture, but there is a knee internal, the patella you can see there are internally rotated, and then you can see a supinated foot where actually you can see the tibialis anterior standing out. And the third picture is actually an externally rotated. It's from the hip onwards, that is the whole lower limb is externally rotated. You can see an intoing as well as an external. So there are so many pictures and you must make it a habit to look into this attitude, because sometimes that pain may be a primary issue with the knee, or sometimes that can be an issue with the foot that actually reflects on the knee. So the primary pathology doesn't mean that it's only a postural pain. All of the pain is due to the posture, but that is contributing the pain. I also mentioned it yesterday that postural issue is actually contributing the pain. So if you want to treat it fully, you have to correct that problem. So that may be primarily with the knee or primarily with the foot and ankle. You have to find it out. Then again look for signs One is actually you can see a high arched, slightly a cavus on one side, and so you can see the heel. So that is the peekaboo sign. And the other side you can see because of the valgus you have the too many toes sign. So that will give you an idea about the hind heel valgus, or there is a cavus. All these things you can find it out by inspection itself. And this is to find out whether that cavus is due to a hind foot issue or a forefoot issue. So you keep a block on the lateral aspect. If it's a forefoot, if it's a high arched forefoot, that is causing the apparent varus on the hind foot, that will be corrected by the Coleman block test. So you are having the inspection and you are seeing the attitude of the foot and angle, and you are to try to find out where is the basic problem. Then inspection will give you idea regarding the calluses and ulcers. These are very common in neuropathic foot and all. You will see the callus and you will see the ulcers. You have to have a proper examination, and you will see the deformities because of the neurological issues. You will see the deformities. Always look at the toes. And again, don't forget about other sinister causes like melanoma. So always look for pigmentations and vascular issues like there is a, and when there is a CRPS, and also have a proper inspection of the nail and the skin. And don't forget to look at the shoes. Many times shoes gives you a good idea regarding the problem, because whenever there is a deformity in the foot, that is when the person is using a footwear for the long time, that deformity reflect on the footwear. So you can see the pressure and the wearing of the and the shape of the footwear. That will give you a proper idea how the force is applied to the ground. And when you look at the gait, as Zacharias sir told, you have to make the habit of examining properly and then look at the gait in the beginning. And when you are expert enough, when you have gained enough experience, you can probably start with the gait. But always remember that there is pronation for weight acceptance and there is supination for the propulsion. Always remember that. There is pronation. Pronation is a loose packed position of the bones that will enable the body to accept weight. But to move forward, you want the foot to act as a rigid lever. For that, you need supination. So whatever is given is just, that is simply, pronation is for weight acceptance, and as you move forward to the toe off, the foot goes into supination for propulsion. So that you have to, when you concentrate on the foot, these 2 points you need to concentrate. You look the patient, you watch the patient walking, whether in the weight acceptance phase is there pronation, and when the propulsion phase is there supination. If that is not happening, you must understand and you must look for any causes, like there may be tightness of some muscles, or there may be insufficiency of some muscles, especially the gastrosoleus and the tibialis posterior. So in the gait, when you are concentrating on the foot, everything is important, but always remember the pronation for weight acceptance and supination for propulsion. And always do functional test with loading, so that will produce some pain, and grossly you can know that there is some problem. Okay, when you are loading on single squatting and loading, you can know that there is some problem. You will get the, so that is the functional test. And proprioception, especially ankle injuries, especially in the sports injury scenario, when you examine an athlete, the proprioception is very important. So standing on the single limb, and you can modify it with standing on the single limb and looking upwards, closing the eyes to get more idea regarding the proprioception. Then coming to the palpation, this is how you divide the bones, how you divide the hind foot, midfoot and the forefoot, and how you divide the bones. It's very important that you have a very good idea regarding palpation. Usually the Ottawa angle rules that do not come to in a PMR perspective, that is probably in the ER or in the emergency department, when you decide when to take an X-ray, when to take an ankle X-ray, when to take a foot X-ray. That is these points, when these points are tender, and then you cannot take 4 steps in the emergency department, then that's an indication for an ankle X-ray and a foot X-ray. Basically, that reduces the chance of having unwanted X-rays, but it's just for a theoretical purpose. That doesn't serve very well with the PMR scenario. You must know how to identify most of these areas, the bony points. It's very important because many of the structures, palpation plays a key role in identifying the pathology in the ankle and foot. Again, this is one, you have many videos, but always to get a good idea about the surface anatomy, it's better to see and practice on your own body. It's the foot and you can actually practice it in your own body to have proper idea. Start with the medial malleolus, pass your finger to the medial malleolus. You can feel the medial malleolus very easily. Then just go below the medial malleolus. Just go down, vertically down from the medial malleolus. Pass your finger and you will feel a bony prominence. You are first on the medial malleolus, then you pass vertically down, you feel a bony prominence, and then you feel that it is only soft tissue in the sole. That bony prominence is the sustentaculum talae. That is the sustentaculum talae. You must remember the sustentaculum talae as an attachment point for the tibiocalcaneal ligament and also for the spring ligament. It's a very important landmark. So you must know, from the medial malleolus, go straight down, you get a first bony prominence you get is the sustentaculum talae. That point, then you move forwards. Move forwards from that point and you will get the second bony prominence. That is the navicular tuberosity. Okay, from the sustentaculum talae you go forwards in the medial plane and you will get the navicular tuberosity. So now you know the sustentaculum talae, the navicular tuberosity, and palpation of end spot anteriorly for the navicular stress fractures. Then go to the, so these are the basic minimum things on the medial side, because when you reach the navicular tuberosity, you can actually move forwards to get the cuneiform and then you can move forwards towards the metatarsal. That is easy. Coming to the lateral aspect, you can get the lateral malleolus very easily. It's very easy to palpate. Then you can hold in between the lateral and medial malleolus, you can hold the dome of the talus and you can actually move that. That is an important area. You have to feel for tenderness, you have to feel for crepitus, you have to move it and see the dome of the talus. You can slightly move forwards to get into the neck of the talus also. That is how you hold the dome of the talus. Then you slowly come, as we came to the sustentaculum talae on the medial aspect, slowly come down on the lateral aspect to get the peroneal tuberosity. You can confirm it by just everting the foot and you will feel the peroneal tendon, and just below that peroneal tendon you will get the tuberosity. And then look for the sinus tarsi. That's a small dip. So whenever there is a ligamentous injury and all, there will be tenderness, and many times you do a diagnostic test by injecting some lignocaine into this area. Okay. Now the bony points I have mentioned, you palpate the medial malleolus on the medial aspect, go down to get the sustentaculum talae, go anterior to get the navicular tuberosity, then on the lateral side the lateral malleolus, in between the medial and lateral malleolus you can hold the talar dome and move it, then you can come down for the peroneal tubercle and you can slightly move forward to easily get the fifth metatarsal. Okay, so these are the major bony points, and when you get these bony points, it's easy to interpret the other areas, because you know the cuboid is in between these areas and the cuneiform here, so that you can make out when at least you have good idea about these bony points. You must have very good idea about the ligaments on lateral aspect and the medial aspect, mainly the deltoid complex and the tibiofibular ATFL complex, lateral ligaments on this side. At least you must have a good idea about this ligament. The bifurcate ligament, all these ligaments are there, but at least you must have a good idea about these ligaments and the syndesmotic ligaments in between the tibia and fibula. Now always I have a reverse learning, because when you are good in actually good in identify the ligaments by ultrasound, you will be definitely good in identifying them by palpation. So this is the position. You can see the position. The first position is actually, this one is for the calcaneofibular ligament and the second is for the ATFL. The ATFL, one point on the lateral malleolus and then you actually turn your probe towards the big toe. That is the direction of ATFL. So palpation also you can use this thing whenever pain in that area. From the lateral malleolus you are actually pointing towards the big toe and your movement is inversion and plantar flexion. Then that will be taut and you can palpate over that area. But when you are from the lateral malleolus, you are posteriorly going towards the heel, towards the calcaneus. That is the point of the calcaneofibular ligament. Okay, and you keep it in slightly eversion and dorsiflexion. So these are the two important lateral ligaments, the ATFL and the calcaneofibular ligaments. You can palpate them. And coming to the medial aspect, you have the deltoid ligament complex. Basically, this deltoid ligament complex fan from the medial malleolus, one side to the navicular and other side towards the calcaneum. It's almost some people call it as a Chinese fan shaped. It's almost this is the shape actually, that is the shape. It spans a great area. Okay. So that area you can palpate for tenderness for the deltoid ligament complex. And you must know, clearly you must know these ligaments, you must learn them, which are the important ligaments, which is the origin, which is the insertion, when these ligaments are, in which movement these ligaments are taut and injured, these you have to learn. Plantar fascia, always you do that. So keep it in a dorsiflex position and the medial calcaneal tubercle is the point where you actually palpate. And you can actually palpate the fascia throughout its attachment to the MTP joint areas. You can palpate it along and feel that any bumping or any structures or any fibrosis over there. Then for the forefoot, you can actually palpate for the sesamoid bones. You can palpate the MTP joints and Morton's neuroma. That we will come to that later. Then manual muscle testing. You know all the muscles, the dorsiflexors, plantar flexors, the inverters, everters, all the muscle. You must know the proper way to test them and you have to test all these muscles and do a proper vascular examination. And if you are not getting proper pulsation, then look for changes look for the temperature, color and the capillary refill because you suspect an ischemia. Then the neurological examination. Neurological examination, basically the things you must know is that the distribution of the tibial nerve, how the tibial nerve actually split into the lateral and medial and lateral plantar nerves. Then the peroneal nerve, superficial and deep peroneal nerve, their distribution area, the sural nerve. You must be thorough about these things. And the local neurological pathologies that you usually encounter is, one is the tarsal tunnel syndrome, and second then the Baxter's neuropathy, and then the Morton's neuroma. So the Morton's neuroma, there are many tests, but a very good test with good sensitivity and specificity, you can see that the thumb index finger squeeze. You actually squeeze in the metatarsal, in between the two metatarsals, involved metatarsals, you actually squeeze that area, and that pain is actually, that test is having good sensitivity and specificity. Actually, you have the Mulder's click and other tests. Many tests are there, but this is the one with the best sensitivity and specificity. Tarsal tunnel syndrome, you can have different tests. You can have the dorsiflexion away. You keep the angle in dorsiflexion and eversion and keep it for some 5 to 10 seconds, and you will have the burning and tingling sensation over the distribution of the nerve. Or the just reverse also you can do. You can keep it in the plantar flexion inverted position, press for around 30 seconds. Again, that will produce the same result, and you can look for the Tinel sign. So you must always remember the structures on the medial side. The very famous code for that. Tom, Dick and very nervous. Harry, the tibialis posterior, the flexor digitorum, artery, vein and the posterior tibial nerve and the flexor hallucis. That is the order. You must remember that, and there is that is the point where you have to look for the Tinel sign in a tarsal tunnel syndrome. Then coming to the special test, actually unlike the shoulder, there are not so many special tests in ankle. There are only a few. One is the anterior drawer test. That is for the ATFL, for the lateral ligament, mainly for the ATFL, for laxity. As I mentioned yesterday, sprain and this thing, actually this shows that there is laxity, Basically, this test is described in different ways, but the basic simple thing is that you actually stabilize the foot proximal to the angle you hold over to the lower portion of the leg, and you try to move the foot. So if that is translating much more, that shows that there is some laxity. And then the talar tilt test. What is the talar tilt test? It's basically inversion. You actually again stabilize the leg and you try to invert. So when there is no good support, no good ligamental support on the lateral side, that try to get more inverted. So this is basically a comparison test. More than measurement, you compare the both sides, and if you think that an inversion is more on one side, that shows that there is some laxity on that portion, the lateral ligaments. Maybe there is a sprain or injury. So that depends on the other examination also, like your palpation for tenderness and hematoma. That decides whether there is an injury or not, but you are sure that there is some laxity. So some books actually mention it as you can keep it in different positions and that denote different ligaments, but there is not much evidence for that. But you can surely say that there is some amount of laxity, probably there is a ligament injury by doing these tests. Then there is syndesmos. Syndesmos injury means there are ligaments between the tibia and fibula, the tibiofibular ligaments and the interosseous membrane. So these can also be injured. The problem is that there can be fractures associated with this injury. This injury, whenever you do an ultrasound also, you are very keen to know about this ligament, because ATFL is probably the most common injury you get, and you get patients referred for the ATFL injury many times to put PRP and all, but many times the tibiofibular ligament also will be injured along with the ATFL, and that is very likely to have an unnoticed fracture above. So it is very important that you look for the syndesmotic injuries. How you look for that? There are the external rotation test, syndesmosis ligament palpation, and squeeze test. External rotation, simply you externally rotate and you will get pain over the areas of this ligament. Simply you external rotate, and it is a very good test. You will get pain over the areas. Then you know the ligaments, you know the areas of the ligaments, the tibiofibular ligaments, and you palpate over these areas. Anteriorly and posteriorly you can palpate over these areas. Usually these ligaments are anterior, you can actually see those ligaments. Actually you have the anterior, posterior and transverse, then the interosseous membrane. Your palpation is mainly for the anterior and posterior tibiofibular ligaments. Those areas you can palpate. So if there is tenderness, that is indicative that there can be a syndesmotic injury. You do a squeeze test, especially when there is interosseous membrane pathology. You do a squeeze test and you will have pain downwards. So that actually tells you about the syndesmotic injuries. Your palpation, then the external rotation test and the squeeze test tells you about the problems with the syndesmotic injury. Then the talar dome palpation, I just showed you how you get the talar dome. So in the plantar flex position, you do the talar dome palpation, and there can be synovitis, there can be anterior impingement or osteochondrolation, crepitus or tenderness. You have to look for that. Then anterolateral impingement. So these 6 points, when the 5 out of these 6 is positive, it is said to have the anterolateral impingement. Again, if you make the patient stand this way, when there is an anterolateral impingement, you will have pain. And the posterior impingement just the reverse way. That is when the angle is in maximum passive plantar flexion, you have pain. Achilles tendon rupture, these tests are very common, and you know that Thompson test, just squeeze it and normally you will have a passive, you will have a plantar flexion. When there is a rupture, you will not have that. Matrix test, you just put it in 90 degree, make the patient prone lying, put it in a 90 degree flexion. So normal, if there is the discontinuity of the Achilles tendon, it will drop into dorsiflexion. And you can palpate also. These are very sensitive and specific tests. So practical approach, actually you have to watch the patient from front and behind, then make him to have a single limb stance where you can actually test the balance and you can test the function of the plantar flexors, check the gait, single and double heel raise, look for inversion before lateral flexion. That gives you an idea of the problem with the tibialis posterior, that is overstrain, inversion before lateral plantar flexion when you are raising on heel. Then patient sit on the couch, do the pulsation, skin scar sensation, SLR manual muscle test, ROM and palpation. Then depending on these tests, you are focusing on area, then do a special test as and when needed. So that's a practical approach. So that's the end of the presentation. Thank you very much.